Hello, my name is Ashley Ring, and I'm a registered nurse. Today, I would like to discuss the effect of skin-to-skin therapy on newborn homeostatic balance, thermoregulation, and breastfeeding success. We all know that childbirth and the newborn transition from intrauterine life is a naturally occurring process. Cultural beliefs and medical knowledge, however, can affect this process. Currently, our healthcare practices include separation of moms and their newborns at birth. The alternative to this separation is skin-to-skin care. Skin-to-skin care involves an infant wearing only a diaper being placed directly on mom's bare chest, covering the two with blankets. Skin-to-skin care will be referred to as kangaroo care in parts of this presentation and in the literature review. So what's the big deal about skin-to-skin care? What's the problem? Well, historically, skin-to-skin care was routine. It was just how things were done. Advancements in medical knowledge and technology have led us to use medical devices that may be unnecessary, particularly our knowledge on hypothermia and its negative effect on newborns. Advancements in this medical knowledge and technology has led to the separation of mother and infant as routine care. Newborn care practices that utilize unnecessary medical devices increase medical costs unnecessarily and also may negatively affect the overall health of the newborn. That brings us to our question. Compared to newborns who do not experience skin-to-skin contact at birth, do newborns experiencing skin-to-skin contact at birth experience more positive outcomes, specifically better homeostatic balance, thermoregulation, and breastfeeding success? The theoretical basis for this inquiry is Betty Newman's systems model. According to Nursing Theory 2015, this theory holds that each patient has implicit internal resistance factors known as lines of resistance. These lines of resistance function to stabilize and realign the patient to their usual state of wellness. Also, according to Nursing Theory 2015, stress acts as a source of energy depletion and disorganization that moves the client toward illness. Using this theoretical approach, keeping infants in close proximity to moms would reduce stress and aid in their illness prevention. The methods used in this inquiry include a literature review using Medline and other peer-reviewed journals. Search keywords utilized were skin-to-skin therapy, skin-to-skin care, and kangaroo care. Current material within the past 5 years was utilized. Older materials were utilized to identify trends in the data and to review original data as well. That brings us to our literature review. In 2014, Agdas, Talat, and Sapide conducted a randomized clinical trial in an Iranian hospital. They included only healthy moms and infants and vaginal deliveries in their study. They sought to determine the effects of skin-to-skin therapy on mom and infant breastfeeding self-efficacy at 28 days postpartum. They aimed to demonstrate if skin-to-skin therapy could be performed with or without risk of hypothermia to the newborn. Their study revealed that skin-to-skin care actually enhanced breastfeeding self-efficacy and enhanced exclusive breastfeeding. This was all done without risk of hypothermia to the newborn. Their study implies that hospital and newborn practices can directly affect breastfeeding success. Also in 2014, Baranvan, Velzadia, Hossanabadi, and Pornia conducted a randomized clinical trial in Iran. They included healthy infants born via C-section in their study. The purpose was to determine the effects of skin-to-skin therapy on infant temperatures and breastfeeding. This study revealed that C-section neonates placed skin-to-skin were not prone to hypothermia, and breastfeeding initiation and success rates improved. So this was a very similar study with very similar findings to the previous study. This study implies that newborn care practices eliminating maternal and infant separation can be performed without risk of hypothermia to the infant. It also implies that newborn care practices eliminating maternal and infant separation can directly affect breastfeeding success. Bera, Ghosh, Hazra, Munyan, Singh, and Som in 2014 conducted a quasi-experimental study on the effects of skin-to-skin therapy on low birth weight infants. Low birth weight infants were described as weighing less than 2,500 grams at birth. This study included temperature, respiration, heart rate, and oxygen saturation measurements immediately before and after kangaroo care. Measurements were done for 3 consecutive days. This study revealed an increased regularity in respiratory rate and improved oxygen saturations during kangaroo care. It also revealed improved neonatal thermoregulation, and in some cases, mild states of hypothermia were actually corrected by kangaroo care. This study supports kangaroo care as easy, economical, and a way to improve physiological parameters in low birth weight infants. It reveals that despite the simplistic nature of kangaroo care, there are still barriers such as maternal ability to provide appropriate kangaroo care. In 2014, Conde, Agudelo, and Diaz-Rosello conducted a meta-analysis of 17 randomized clinical trials. These trials compared kangaroo care to conventional newborn care and early kangaroo care to late kangaroo care. Low birth weight infants in various regions of the world were included in these studies. So this was a good study to get results across populations and cultures. The study revealed that kangaroo care is associated with reduced infant mortality in low birth weight infants, improved weight gain, and increased breastfeeding. This study supports kangaroo care as a means to improve outcomes for low birth weight infants. Moore, Anderson, Bergman, and Doswell in 2012 also conducted a meta-analysis. They included 34 randomized clinical trials. Included in the trials were infants born via vaginal and cesarean delivery. These infants were from various regions in the world. Again, this study also encompassed varying cultures and populations. It also included healthy and unhealthy infants and mothers. The study concluded that babies exposed to skin-to-skin contact actually interacted more with their moms and cried less. Moms participating in skin-to-skin care were more likely to breastfeed and for longer durations. While suggesting that improved breastfeeding may be the result of improved blood sugars and physiological parameters, this study was limited on the assessment of the physiological benefits to the infants, so this is an indication for further research in this area. Suzuki in 2013 conducted an observational cohort study. She studied women in Japan to determine the effects of early skin-to-skin therapy on breastfeeding at 1 month postpartum. The study included only healthy infants and mothers, and it should be noted that the Japanese typically embrace a culture that is hesitant to utilize skin-to-skin therapy because of safety concerns. The study actually revealed that breastfeeding rates in those participating in early skin-to-skin therapy were higher than those who did not. This study was also beneficial because it produced evidence that supports the safety of skin-to-skin therapy for the Japanese. Takahashi, Tamakashi, Matsushima, and Kawabe in 2011 conducted a non-experimental research study. Their study evaluated physiological parameters in newborns receiving skin-to-skin contact of different initiation and duration times. In this study, early skin-to-skin care was care began within 5 minutes of birth. Longer skin-to-skin therapy was conducted for more than an hour after birth. Heart rate and oxygen saturations were measured for 30 minutes post-birth. Salivary cortisol concentration was measured at 160 and 120 minutes post-birth. Their study revealed that earlier and longer durations of skin-to-skin care are beneficial for cardiopulmonary stability and reduction of infant stress. To summarize the literature, evidence supports that skin-to-skin therapy in newborns is a means to improve homeostatic balance, thermoregulation, and breastfeeding success. There is also evidence of improved maternal and newborn bonding when skin-to-skin therapy is used. Studies demonstrate positive effects of skin-to-skin therapy on infant thermoregulation, and literature supports that hospital practices regarding newborn care can directly affect breastfeeding. There's a wealth of evidence that supports skin-to-skin therapy as a safe means to enhance breastfeeding initiation and success. This is particularly important because the World Health Organization, the American Academy of Pediatrics, and the Joint Commission all support breastfeeding as the best means to feed infants. Despite the supportive evidence available, there are implications for further research in the areas of skin-to-skin therapy's impact on physiological parameters, specifically heart rate and oxygenation. So, who is important in this topic? Who are the stakeholders? Well, pretty much everyone, the entire population. Bedside nursing personnel, mid-level managers, administrators, healthcare payers, healthcare consumers, and taxpayers. Ethical considerations for this type of research include the principles of benefit and harm. Infant maternal health will not be compromised for any research purpose. Strict inclusion and exclusion criteria will help select subjects in which the benefit of therapy outweighs the risk of harm. Respect for cultural diversity and pluralism will be considered, especially since childbirth practices are subject to strong cultural influences. The principle of cultural, religious, and personal beliefs play a role in how a new mom perceives her infant who hasn't been bathed and contact with birth fluids. These perceptions and beliefs may impact her desire to perform and how well she performs the intervention of skin-to-skin, which could potentially affect results. Informed consent using signed consent forms and the assurance of anonymity will be made available to participants. Potential barriers to skin-to-skin therapy that should be considered include clinical contraindications, such as an unstable newborn or mother. Staff or maternal knowledge deficits regarding skin-to-skin therapy benefits, and knowledge deficits on how to appropriately apply skin-to-skin therapy. Cultural practices on newborn care and personal perceptions. I'd already mentioned the exposure to birth fluids, infection control concerns, and previous birth experiences. Potential funding sources for this type of research include the American Nurses Foundation, ANF. The ANF supports clinically based research and also provides grants to novice and experienced nurse researchers. The ANF supports research regarding nursing ability to improve quality of life across the lifespan, certainly starting out as early as the newborn period has an impact on the entire lifespan. The Association of Women's Health, Obstetric, and Neonatal Nurses, AWON, is also a potential funding source. AWON supports nursing research on women's health issues, obstetric, and neonatal nursing issues. It also supports clinically focused and outcome-based research and research on nurses' role in delivering cost-effective care. It was previously mentioned on the impact of unnecessary medical devices resulting in unnecessary medical costs. So they might have an interest in our project. To summarize, skin-to-skin therapy is cost-effective. It requires no special medical equipment. There are minimal barriers to skin-to-skin therapy. Main barriers include knowledge deficits and clinical contraindications. There is evidence supporting positive effects of skin-to-skin therapy on infants. Healthier infants result in decreased healthcare costs and a healthier population. Skin-to-skin therapy enhances breastfeeding success, which alone may lead to healthier infants. Thank you. The following references were utilized to complete this presentation.